Hi, my name is Dr. Daniel G. Miller. I'm a board-certified chiropractic neurologist practicing out of complementary medicine and healing arts, 27 Jennison Avenue, Johnson City, New York. My telephone number here is 607-729-0591. You can also reach us on the web at www.naturallywell.us. The topic for today, we're going to talk about visual vertigo. Many people know and understand that vertigo means you're either spinning or wooziness or disequilibrium sensation that occurs. Now, they occur in a lot of different ways. Sometimes you get the stones in our ears that causes benign paroxysmal vertigo or positional vertigo. You can have Meniere's disease, where you've lost of hearing, the ringing in the ears, and the vertigo. Oftentimes we don't know why that causes. Sometimes there's a tumor. Sometimes as a result of an infection, people get dizzy. Congestion in the ear sometimes causes dizziness. And we always are thinking inner ear when we hear the word vertigo. Well, the research also shows that sometimes it's the visual input system that really can trigger some people to have vertigo. And when that happens, what type of when you see that, you might hear someone say, you know, when I'm walking down the aisle at the grocery store, everything kind of gets a little whoa. And they may say, you know, when I'm driving, all of a sudden everything gets dizzy, and I have to like stop, or I can no longer drive. You know, I have to close my eyes, and when I close my eyes, it all gets better. Well, they've done some studies on this, and they found that it's not always due to the semicircle canals or the utricle and saccule, but rather sometimes it is really a visual proprioceptive problem, whereby the stimulation coming into our eyes is so powerful that and of course our visual system is related to our vestibular system, that it causes a sense of disequilibrium. And though the mechanisms are not well understood to why this occurs, there's some things we can talk about in doing. The most important thing that you first have to do is you have to get a proper vestibular evaluation, including a history, past medical history, and of course a physical examination. In the physical examination, we need to make sure that one of the other more common forms of vertigo is not the underlying cause. And again, that can range from otolithic formations, either in the utricle and saccule or in the semicircle canals. It can be an acute vestibular neuritis, into which you have inflammation of the vestibular apparatus. It could be an infection, it could be severe allergies, it could be a tumor. Those all have to be looked at and seen, is that causing a problem? We'll be looking for things like nystagmus in the eyes, putting your head into a position, does that evoke more of the dizziness? Once we have determined that you aren't suffering from one of these other conditions, and we may even do some challenges and some initial treatments to see, does that really improve it? And a lot of times it will improve it, but it will not remove the situation. Once we've gone through that positioning stuff and we're looking at everything, we'll see that oftentimes this type of dizziness, this vestibular vertigo, has been a chronic situation. It kind of has come and gone. It doesn't necessarily last long. It may be as quick as a couple seconds. It doesn't really match up with what we typically would look at as a direct positional vertigo or even a vestibular neuritis, because of the chronicity of nature. Yes, you can have a chronic neuritis. Usually your dizziness is going to be more profound, it's going to be longer lasting and more debilitating. And certainly it's not necessarily going to go away if you just simply close your eyes. So When this occurs, we can do a couple other testing after that to see how your visual system works. Now, we'll have taken our finger and we'll have moved your eyes in pursuits following our finger. We'll have done some vestibular ocular, where we have you stare at the finger, keep your eyes fixed, and move your head in various positions. And we may even move that back and forth to see if there's any problem there. And they really don't show up too great. Maybe a little, certainly in a position it may be more provoked, but it's nothing is seeming to resolve the situation. One of the things I like to do to see if, okay, vestibulo-ocular seems relatively intact. It's not the primary cause. We're not seeing a complete loss of vestibulo-ocular. We're not seeing a real huge breakdown. In fact, we may see that the individual can quite easily do this, and it neither improves or evokes more dizziness. So one thing I do is I use a fist challenge test. I have you look at my fist. I'm about 14 to 18 inches away, usually around 18, maybe 18 to 20 inches away. And I have you focus on it. Again, this is a vestibular ocular, but instead of looking at it in the horizontal and vertical plane, we're now looking at it in roll. And for this, just for the sake of the video, I'm going to use my little orange colored piece of paper here to further show. And I have you focus in on this. And as of right now, you should be feeling okay. And I slowly start to turn it. And we're looking for signs of problems, maybe looking at our lips, our eyes moving. And you note all of a sudden now I feel that nausea, that wooziness going on. Okay, we come back this way. And we see, does it occur this way or does it not? We note where it started. So if it started here, we take note that it was at this point. We note here if it was at this point. So we got that brought out. Now, as you know with our eyes, that they're yoked, so they move together. You know, if they're going back and forth, up and down, or do they intort and extort? Right, we keep the world upright, right? So there's tilt mirror imaging testing you can do where we have this is the correct vertigo, right? We're upright, we're perpendicular to the ground. We started at a skew here. We have the patient move it to where they perceive the proper location is. A quicker way in the office to do this is I did my tilt test. That bothered me. I tilt the head this way. Oh, hey, that's fine. Look, now I can go like this. We see there's going to be some kind of skew. Now, certainly we should follow up with more complex testing if possible to see if it's off. But it's not going to change the fact that there's some kind of skew there and roll, and we have to do some kind of exercise or procedure in order to improve that. The other thing I then do is I always recheck for dysmetria. Is there anything going on here or here? A lot of times, to the more involved side, we see something off with the cerebellum. Let's say in this case, the left cerebellum. I also check back here for any tenderness. A lot of times we'll find tenderness as the trap comes up and goes into the nuchal lines, to the inferior nuchal line, and see is there any tenderness there, is there any tenderness in the belly of the trap, of the upper trap, and as well as the SCM, especially if they go to one side and it diminishes the dizziness. So your sternocleidomastoid, you know, the trigger points will cause kind of facial pain, some moving back and forth appearing, and it also causes dizziness. If you look it up in Travell, she talked about that a lot, that could be the dizziness, and that can be one of the secondary causes that you're not thinking, especially if you can't find a good vestibular reason. the sternocleidomastoid can certainly cause that to occur. As well as with the upper tract. And when you think about it, our vestibulospinal tract, in reticulospinal and tectospinal tracts are so intimately related to our head and neck and our ability to be aware of our environment, as well as coordinated eye movements. So those can go off. Oftentimes you'll see a postural deficit, forward head carriage, head tilt. So those come into play. You know, you can also do the same fist test, and you can also see how sway occurs, having the patient stand up and provide the challenge and notice which direction to sway, and then as a trained practitioner, go ahead and treat the person. Now, habituation exercises is the best way to treat it. Now, if you have hemistim or a hemistimulation type system with OPK, you can utilize that. That's been shown via the research to be a really good way. Again, taking your clinical findings as it relates to the optokinetic testing. If patients aren't able to do that, or they don't have a computer system that runs hemistim anymore, they don't have an iPhone or the iPhone app, then what do? We're still working, especially if it's a roll, skew, deviation, and you train them how to do the test that we just did. You have them go, you know, I'm going to turn to the side here, push this back so we get a little bit. You know, we're going to be out here about, you know, 18 to 20 inches, right? And I mean, I'm just using this. You're going to use your fist, right? But this doesn't work so good. So you're going to have this out here. You're going to be focusing on that, and you're going to start to turn, and you're going to notice, where is that? That makes me feel weird. And then we're going to turn back. And from this way, again, this would be the fist, and now I'll use my fist here. We'll turn. There, that bothers me. Okay. There, that bothers me. That is your functional range, right? So obviously in this particular habituation exercise, it really works best if you can have somebody there to help you. If you don't, you can use like your computer monitor or a mirror, right? You can be looking at it, and you can have like an arc, forming an arc. And you can follow that arc. You could take, you know, put on a mirror, get a crayon, piece of string, draw yourself a circle. Or you could set a bowl in front of you, follow the circle, note where the perceived sense of disequilibrium occurs, mark it. Go to the other side, mark it. Then what you're going to do is you're going to go just to that point and then follow the arc back around to the next side, right? So again, if I had a piece of paper here, you know, I'd have the arc, and I would mark my arc to where it was. Now, in the office and at home, you know, I find that doing quite a bit of soft tissue massage, manipulation with that is very helpful. So we might make sure we're teaching, you know, a pincer grip, compression of the upper tract, overpressure at the base of the skull to work on that, to see, does that improve. The other thing is, was there any signs of dysmetria? Making sure we give the correct cerebellar integration exercises in order to bring that up. Really important to really watch on that, because a lot of times when you have a pretty significant or chronic roll deviation there, that just doing a pure, let's say, left cerebellar stimulation, where we're doing pursuits to stimulate, really watch which quadrant to affect, and look for the signs of breakdown, also the signs of fatigue, is there tearing, bloodshotting of the eyes, inability to stay focused on your finger, because those are really important in treating this, because we may think, well, geez, you know, left cerebellum will do it, but we got to break that down a little bit into the appropriate components, and the floccular nodule and the vestigial component of it, and make sure, is it just going to be into the lower quadrant, or is it going to be the whole, is it just going to be in the upper quadrant that we need to work on first. And of course you can retest, your cerebellum evaluation in order to see which one of those is going to be important in bringing up the brain properly to help address this role skew deviation of visual vertigo. So take that into mind. And again, how long do we do this? Well, once we get started with it, we want to do it again, just like for all things neuroplasticity, at least 45 seconds, preferably a minute. Take a break, rest your eyes, and then repeat it 2 to 3 times. And you want to do it 2 to 3 times a day. It's been a chronic process to retrain it that is not necessarily going to be the quickest result. However, with habituation exercises, we're still probably going to continue to give you the exercises to move your head, do the vestibular ocular, then do this way, just moving your head, doing the vestibular ocular. So some of the things we're going to continue to give you to better integrate, especially the vestibular ocular stuff, using visual acuity in order to help try to dampen down that hyper excitability of the vestibular proprioceptive system. So it's really important that if you have this and you're starting this, to understand this isn't an easy solution, and this is just the first example of habituation. There's more to the process, and it really needs the importance of understanding to stay in care. Otherwise, it's not going to improve, and you're just going to be very frustrated. So proper diligence is really important here. Trying to stay motivated. Look for those little gains. Did you walk down the hall and only have it happen once versus the whole way down? Are you able to now look from your phone on your desk to your computer and not feel woozy? These little things are really important to look for because it's a chronic problem typically. It's not something that just doing these for a week is going to improve. It is a committed engagement that you have to make with yourself to say, all right, we're going to try to address this. I may not quite understand all the neurology that Dr. Miller talks about. That's really not important. The point is, as we find the problem and show you how to start doing remediation, that you're willing to take that leap of faith and say that I'm going to commit to this and give it all I got to try to improve, stay in care, keep communicating, so that we can take the information, make the adjustments necessary to the program. So again, if you have any questions or concerns, give me a call at 607-729-0591. You can also email me through our website at www.naturallywell.us. And keep trying, keep turning. Note if you got improvement, stay diligent to the program, and come back and see us again soon. Thank you, be well, and have a good day.